Hi, my name is Anisur Rahman and I'm a professor of rheumatology at University College London. It's a huge privilege to be able to give a talk at the SLE Euro conference in Stockholm, and this is a session particularly for patients, and I've been asked to give a short summary of what I said for Lupus Europe. So my talk was about the old and the new DMARDs. So DMARDs stands for disease-modifying anti-rheumatic drugs. So these are not drugs which change your symptoms. They don't make you feel better straight away. They affect your immune system to reduce the activity of the disease. So they asked me to compare old ones and new ones. Old ones are things that many people will be familiar with, like mycophenolate, for example, azathioprine, hydroxychloroquine. New ones are what we call the biologic drugs. We call them biologics because they were developed by understanding the biology of lupus and because they're made in a particular way which uses biology. And the ones you may have heard of are rituximab, belimumab, and anifrolumab. Now, in my talk, I compared the experience of rheumatoid arthritis with the experience of lupus. Rheumatoid arthritis, there are a lot of these biologic drugs, a lot of them, a lot of choice, a lot of patients on them. It has revolutionized the treatment of that disease. Lupus, not so much. There are not so many biologics available and not as many patients are on them. So why is this? There are lots of reasons for this. But in a nutshell, it has proved very difficult to show that biologics are effective in lupus. It's hard to do trials in lupus. It's a rare disease, a complicated disease. It's hard to prove what works and what doesn't work. There have been trials, and some of them have not met their endpoint. When not met their endpoint, it means they statistically were not able to prove that the new drug was better than the old drug. And I went over some of the reasons for that. But remember, the old drugs are still pretty good. And one of the reasons why the new drugs weren't shown to be better was that in those trials of patients on the old drugs, things like azathioprine and mycophenolate did pretty well. So if you're on those drugs, you're on good drugs. So what will be the place for these new biologic drugs in the future? It could be in people who just don't manage on the old drugs. We call these people refractory patients. Things aren't working that work in everybody else. There is a place for the new drugs in those patients, and they are being used in those patients now. More interestingly, some people have argued that use of the new drugs can reduce or even stop patients' reliance on prednisolone or other corticosteroids. Many patients with lupus are on those drugs for a long time with side effects. If we could invent or discover some drug which reduced our reliance on corticosteroids, that would be brilliant. That day has not come yet, but maybe it will come in the future. There are trials designed to find that out. But till that happens, patients with lupus will still be taking corticosteroids and still benefiting from those corticosteroids. And finally, in the future, we're going to have to decide as a population, as a country, or different countries, what the place for these new drugs is because they're really, really expensive. There's nothing anybody can do about it. That's just how much they cost. That doesn't mean they should never be used, but they will be used only in certain patients fulfilling certain rules. So, future, there will be new drugs for lupus. They'll probably be used in a fairly limited way, and there will be rules about them, but there will be some new drugs, and the old drugs are still pretty good.